I can see you can hear me. So good morning everyone, and thank you for joining this session. My name is Andrea Dall'Asta from the University of Parma in Italy, and I have the pleasure and privilege to welcome you to this last third day of the ISWOG World Congress and to this very exciting session entitled Big and Small Babies, How to Manage and When to Scan. I have a co-chair who is Professor Da Silva Costa from Australia, and I have two eminent speakers with great expertise in the topic, which are Professor Jerry Visser from the Netherlands and Professor Christoph Lies from the United Kingdom. So before I thank you again for being here, and with no further ado, I will start with the first speaker. So we have Professor Jerry Visser, who will talk about the management of LGA babies. So Jerry, the floor is yours.
Thank you very much, Mr. Chairman. It was a nice party last night. I hope you also enjoyed it.
But unfortunately, I have recovered already somewhat. Good morning. Big babies, how to manage, how to deliver. No conflicts of interest, apart from the fact that I was a big baby, over 4 kilograms, so we might discuss that a little bit later on. Apparently, it's a subject of interest. If you look at articles on management of macrosomia, there are at least 100 a year, so that's 10 a month. And I don't think that you should read all of them, because apparently people don't know how to manage it, otherwise they wouldn't write so many articles about it. At the same time, it's not too difficult, and I hope to show you that right now. Big babies, 2 periods of time, antenatal, risks, do we have to monitor, is there something wrong with that, and labor-related risks. Let's start with the first one. This is a study we did in the Netherlands on birth weight centiles in association with perinatal mortality. We did this study especially to look at the small babies, but the big ones are also there. All perinatal deaths in the Netherlands, singletons, 28-42 weeks of gestation, over 1 million in a period of 8 years. And here you can see the data of mortality after 36 weeks of gestation, when the big babies are usually big normally. And you can see that with a low birth weight, below the 2.3rd centile, there is the highest perinatal mortality. And if you move gradually to the right, you can see that it gets lower and lower and lower. And if you look at it precise, you can see that the lowest perinatal mortality is at the 84th centile, which is about +1 standard deviation. Thereafter, it gradually increases, but if you look at perinatal mortality at the birth weight above the 97th centile, you can see it's still lower than the 50th centile. So what are we talking about? If we subdivide it between antenatal, intrapartum, and neonatal, you can see that on this slide. Antenatal, the red lines, is by far the highest. That's the case in high-income countries. If you go to low-income countries, about 50% of mortality is during labor. In our world, that is low now, and about 80% is antepartum. Blue is during labor, and green is neonatal. Again, the same picture, highest with a very low birth weight centile, and then moving to the right, you can see it get lower and lower and lower again. If we emphasize a little bit on the part to the utmost right, you can see, in fact, that the lowest antepartum death, the stillbirth rate, is at the 95th centile. I mean, that's not significantly different from the 90s or whatever, but it's the lowest. If you look at intrapartum, blue, neonatal, green, that's lowest at +1 standard deviation at 84th centile. And that seems logical. That's a little bit shifted to the left, given the fact that big babies usually are going to be delivered a little bit more, have problems during labor than the smaller ones have. Similar data from Scotland, 500,000 births. You can see antepartum related perinatal deaths, lowest incidence in between the 1997 centile, delivery-related, it's a little bit at the lower weight, plus 1 standard deviation, and they found it also in between the 80th and the 90th centile. So for short-term survival, birth weight should be around the 90th centile. In a way, the bigger the better. This implies that 90% of babies born, in a way, are too small. More or less gross restricted, because optimal is not the 50th centile, optimal in the 90th centile. And maybe in the discussion we may talk about that. And it also holds for long-term outcome. The data from the Barker group, now 30 years ago, birth weight and deaths due to cardiovascular disease before the age of 65. You can see best outcome, lowest deaths occurs at the birth weight about 9.5 British pounds for both women and men, so exactly the same. If you go to data from the United States, a huge study, chronic heart disease and stroke in relation to birth weight. You can see that for chronic heart disease, the lowest incidence at the birth weight of around 4 kilograms. If you compare that to 3.5 kilograms, it is about 40% lower. For stroke, even the lowest rate is for a birth weight more than 4.2 kilograms. So it all points in the same direction. Big is better. Morbidity, cerebral palsy, in relation to birth weight and at the different gestational ages, and also from this slide you can see that the lowest incidence of cerebral palsy in babies with a birth weight of about plus 1 standard deviation. It's all very consistent. So around the 90th centile, lowest perinatal mortality, lowest cerebral palsy rate, lowest cardiovascular risk, and stroke incident later in life. And if the female babies with a weight around the birth weight around the 90th centile, they themselves will have the lowest chance of getting gestational diabetes later in life. It's all very consistent. Apparently, these infants had an optimal intrauterine growth without any growth restraint. I said again, below the 90th centile, it's a little bit worrisome. So what should be the conclusion as to antenatal care? Generally, big babies may be considered to be at low risk for stillbirth. All they need is tender loving care. So that's the only thing you can have to write down. It's only one sentence, tender loving care. Not all that ultrasound, maybe at the beginning enlarged and in twins and the congenital malformation, whatever it is. If that's normal, tender loving care. However, they may encounter more problems during labor. And there is the aspect that we should discuss a little bit more. How good are you with your ultrasound and measuring the size of the baby? A meta-analysis of 2020 of Moraitis, the diagnostic performance of an ultrasound estimated fetal weight of more than 4 kilograms or above the 90th centile at predicting shoulder dystocia. And you can see that 5 out of 6 studies show that it does predict overall the odds ratio is 2.6. Is that good? Knowing that the incidence of shoulder dystocia is quite low? No, it's not good at all. In fact, the conclusion of the authors is that third trimester ultrasound has a weak, albeit significant, prediction of shoulder dystocia. So we have some clue, but it's not very good. So should we induce for suspected macrosomia? According to the WHO guidelines, no, not for healthy women, not for women with gestational diabetes, and they don't talk about type 1 or type 2 diabetes. Do we have randomized controlled trials? Yes, but only a few. The largest from France, from Michael Boulvin, and there are 3 more, and Mr. Boulvin himself wrote the Cochrane Library analysis overall. You can see if you induce at or near term for suspected fetal macrosomia, birth weight will be around 160 grams lower. If you look at the incidence of cesarean sections, no significant difference. If you look at the incidence of instrumental deliveries, no significant difference. Shoulder dystocia is lower. And brachial plexus injury, which is rare, and in this study it occurred only in 2 cases, and none of the 800 of the Bouvin cases, and it is not significant, but it is lower, and if the study would be larger, I'm sure that would become significant. Fractures, more often in expected management. Apical pH, interventricular hemorrhage, no difference. More 3rd and 4th degrees in case of induction. I don't know why. And phototherapy is significantly higher in induction, and that holds for all the studies of induction of labor versus expected management. You induce before the fetus itself has considered itself mature, so you see more hypobilirubinemia. So the conclusion, in settings where obstetrician can be reasonably confident about a scan assessment of fetal weight, the advantages and disadvantages of induction at or near term for fetus suspected of being macrosomic should be discussed with parents. I think that's a very intelligent remark. Although some parents and doctors may feel the evidence already justifies inductions, others may justifiably disagree, etc. And of course we need more studies, etc. So the conclusion is, discuss it with the woman involved and let her decide. So tender love and care during labor, and at the end of gestation, let her decide, so you don't have to do anything at all. What about gestational diabetes? A study a long time ago, 30 years ago, low risk, insulin-dependent and gestational diabetes. If you induce them around 38 weeks, and as compared to expected management, then the induction group has a slightly lower cesarean section rate, less LGA babies, and a lower incidence of shoulder dystocia. Altogether 200 women in this trial, a more recent one of 2016, over 400 altogether in the trial. No difference in cesarean section, no difference in operative delivery, in fact no difference at all between the different groups. If you look at morbidity, there was a higher incidence of low EBCA score in the induction group, and again, a higher incidence of hyperbilirubinemia as indicated before. Logical, but overall no differences. So WHO, no reason to induce for suspected macrosomia. In general, yes, I would agree. However, that may generally be correct, but what about poor glycemic control, neglectors, late diagnosis of GDM, etc.? They're definitely more at risk of dying around near term, but well controlled, etc. Type 1, type 2 diabetes, 1 or 2 slides only. Nowadays in the Western world, we see more bigger babies in women with diabetes than we saw before. That's because of a better control in the periconceptional period, and it means a better presentation, to get bigger. In our world, 50% of infants or women with type 1 diabetes have a weight above the 19th centile, which was much lower 30 years ago. Still, it is difficult to achieve complete normal glycemia, so that's the reason they grow bigger. And with better placenta, they grow even more bigger. Fetal weight may overgrow that of the placenta, and the placenta may be immature. And that may result in hypoxemia, and if women have high glucose values or peaks in glucose, high glucose, not enough oxygen, lactate acidemia, and that's probably the reason why they may die at the end, and that's why we consider that we should deliver them a little bit early. So I would suggest to induce labor if the fetus is macrosomic, and to make it simple, an estimated fetal weight of the fetus exceeds about 3.5 to 4 kilograms, irrespective of gestational age. So if the baby is big, 4 kilograms at 36 weeks of gestation, please induce, don't wait longer. They are at higher risk. No randomized controlled trials, I have to say. And when the cesarean section, when weight exceeds about 2.2 or 2.5 kilograms, depending also on the height of the woman, since the incidence of shoulder dystocia in women with diabetes is about 10-fold higher than that in women without diabetes. And the background, and this is again ultrasound that we did a long time ago, Here you can see longitudinal measurements of head to abdomen circumference ratio. The black lines throughout gestation are non-diabetic women, and you can see that especially the big ones that you see on the bottom right, type 1 diabetes, LGA, type 2 LGA, GDM LGA, you can see there is a very low head to abdomen ratio, far from the normal lines throughout gestation. And the large abdomen implies also large shoulders, and that's the reason why we see such a high incidence of shoulder dystocia in these cases. So, no diabetes, just wait and see. Diabetes, longitudinal ultrasound monitoring fetal growth, which is much better than a single measurement. I guess all of you know that. Especially with diabetes, you can see already around 30 weeks of gestation how the growth profile is. Head to abdomen circumference ratio, induction of labor with estimated fetal weight is more than 4 kilograms in the cesarean section if they're slightly bigger. Thank you very much for your attention.
So, difficult act to follow, but I'm going to be talking about small babies. My name is Christoph Lees. I've just realized I've been lecturing with Jerry for so many years, and I didn't know you were a big baby. Which centile were you on?
That's why I'm still so healthy.
Now, do you know...
It's true, isn't it?
I'm the growth-restricted baby of a pre-eclamptic mother, and my weight was 2080 at 38 weeks. Please, someone work out the centile.
Look at the difference between
So anyway...
And then to realize that I'm 40 years older than he is.
Which makes me 25. Good. So, no disclosures apart from the disclosure I've just made. I've been asked to talk about Dopplers in small babies, and it's a bit tricky because if you're from how many people are from the US here? Probably not that many. Okay. So please excuse my comments about the SMFM. I'm going to be very nice about them, but I'm just going to say that small babies in the US are slightly different to small babies in UK, Europe, Australia because of the definition. And I'm going to be referring very much to the ISWOG guideline, top right. I'm going to be talking a bit about SMFM, important organization, but there are clear differences, as you know, in the diagnosis of small versus fetal growth restriction. And that is the key, that in the States, a baby is growth restricted if it's less than the 10th centile on estimated fetal weight, or AC. In Europe, UK, other parts of the world, we might choose a slightly different definition based on the consensus definition, which is a really important paper. And this is the Delphi consensus from 2016 by Sanne Gordijn from the Netherlands and team. And Aris, I think I've spotted Aris in the audience, and Baski and others, Ahmet Bashat. I'm going to refer to this because I think this is the best way to define a growth-restricted baby. And classically, we've split it into early and late growth restriction, but more of that to follow. The important point here is that a baby is small because it measures small, but also because there are Doppler changes, and that tells us it's at risk and growth restricted. So my lecture is which Dopplers when? Well, people say to me, well, Dopplers aren't really useful in growth restriction, or when should you use Dopplers? And I say, well, let's split it into diagnosis, monitoring, delivery timing. Let's then split it into early growth restriction and late growth restriction. Now, I'm not trying to confuse, but all these are different. Early growth restriction diagnosis is different to late growth restriction diagnosis, and they require a different Doppler set, if you like, to help you clinically. Let's start with the uterine artery. Well, I know that many of you will measure the uterine artery when a baby is small, even if it's at 36 weeks or 22 weeks. What do we know about uterine artery Doppler in terms of international practice or definition? Although I measure the uterine artery whenever I see a small baby, and I actually think it's quite useful for longitudinal monitoring, if we go to what international consensus is, uterine artery Doppler is useful in diagnosing early growth restriction. It's not particularly useful, or hasn't been shown to be useful, in monitoring or delivery timing. And how do we know that, or what authority tells us that? Well, it's the Delphi consensus. Less than 32-week growth restriction, uterine artery Doppler is an important prerequisite of diagnosis alongside umbilical artery and AC-EFW less than the 10th centile. Let me just explain this. So a baby can be growth restricted if it's less than the 3rd centile, or if it's less than the 10th centile with abnormal uterine or umbilical Doppler. Let's move to probably the mainstay Doppler for diagnosis management. And you'll see that umbilical artery Doppler has a yes in every field there for diagnosis, for monitoring, delivery timing. But it's important also to know that although it's a yes, we don't actually necessarily have randomized control evidence to tell us that that is the right thing to do. But this is consensus and observational studies. So umbilical Doppler, if you're going to do any Doppler, I think we'd all agree, and ISWOG would agree, and SMFM would agree, umbilical artery is the mainstay. For early growth restriction, as I showed you earlier, you can diagnose on the basis of 10th centile uterine artery Doppler or umbilical artery Doppler, greater than the 95th percentile. Please use PI, pulsatility index. SD ratios, AB ratios become problematic and in terms of good reference ranges, so we tend to use pulsatility index. Late fetal growth restriction, again, the umbilical artery is important in diagnosis, either on its own or combined with the middle cerebral artery as the cerebroplacental ratio. So, diagnosis. What about management? Well, we all do umbilical artery Doppler all the time. I think it's a very frequently performed examination. You'll see there absent end diastolic flow. Does it matter? Well, the data we have here is not from randomized controlled trials, it's from observational studies. And abnormal umbilical artery Doppler, just knowing it's there, somehow reduces perinatal mortality by 40%. This is an ancient slide that I made many, many years ago. I haven't changed it much because it's actually rather good. It's that 40% reduction in perinatal mortality if in high-risk pregnancies umbilical artery Doppler is done. It doesn't actually tell you when to deliver, so we've got to join up the dots. This doesn't tell you if you've got absent end diastolic flow at 32 weeks or reverse end diastolic flow at 29 weeks when you should deliver the baby. It just tells you that by doing the umbilical artery Doppler, probably because you know that baby is at much higher risk, because the Doppler is abnormal, that's why you monitor the baby more carefully and get a better perinatal outcome. I said I made that slide 20 years ago, but right up to date, or nearly up to date in Cochrane terms, 5 years ago, 2017, the most recent review, a Cochrane review, showed almost an identical reduction in perinatal mortality, a risk ratio of 0.71, as you can see just in the middle there. And that's for perinatal mortality. So we can see consistently that umbilical artery Doppler reduces perinatal mortality. Now, this table comes from a paper from the American Journal on fetal growth restriction and opinion that I and many US, European European authors wrote, including actually those here on the stage. And we looked at SMFM guidance and we looked at the ISWOG guidance. And the interesting thing is that all of us agree that umbilical artery Doppler is important. And actually our recommendations for delivery based on umbilical artery Doppler abnormalities are very similar. So reverse end diastolic flow, we would all agree that a baby should be delivered at 30 to 32 weeks, absent at 33 to 33, 34, and raised PI once you get to term. So no major difference there. Okay, we're now getting into a slightly more controversial area, middle cerebral artery Doppler. And this is something that's become a hot topic. Really, I'm fascinated, actually, that middle cerebral artery was talked about by Katia Bilardo, who's sitting here in the front row, and others, back in the late 80s, early 90s. And then it dropped out. And then it came back in a major way, probably from 2010 onwards, when people realized that middle cerebral artery Doppler and changes in the cerebral Doppler actually were important. But we didn't know how they were important, how they should influence our management. So yes, for late FGR diagnosis, MCA is one of the characteristics. For monitoring, well, we all measure the middle cerebral to monitor, but we don't know about timing of delivery because there isn't good evidence. So I'll take you back to that slide. Late fetal growth restriction, not early, late cerebroplacental ratio is an important, is an important diagnostic criterion. But how predictive is cerebral artery Doppler? Well, it sort of is, but it's not great. There is an association between abnormal cerebral artery Doppler and adverse outcome. You can see that here. That red dotted line, the red hashed line, the top line, shows perinatal mortality. And that gives you what's called an ROC curve, sensitivity versus specificity. So there is some evidence that cerebral Doppler is predictive, but it's weakly predictive. And all these papers on cerebral Dopplers, this is from a few years ago, what I'd say is they all show that cerebral Doppler is associated with adverse perinatal outcome, but that is a completely different matter to prediction. The Truffle-2 study, many in this hall and on Andrea here from Parma are involved in the Truffle-2 study, which is trying to answer this question. So babies from 32 to 37 weeks, when the umbilical cerebral ratio, umbilical cerebral is just CPR the other way around, is increased, we randomize these women to either immediate delivery in late preterm growth restriction or delivering based on computerized CTG. So hopefully this will give us an answer as to whether composite perinatal outcome is better if you deliver when you see signs of cerebral redistribution compared to waiting a little bit. And that study is ongoing and doing well. We've recruited over 2,300 small babies and randomized just under 300. So SMFM says you shouldn't do middle cerebral artery Doppler. I suppose from a purist point of view, you could say that it hasn't been shown to be effective in randomized controlled trials, but there again, in perinatal medicine, where do randomized controlled trials direct us in management? Often we don't have them. So in the ISWOG guideline, we've taken what I think is a pragmatic view that if there's significant cerebral redistribution in a small baby, then 38, 39 weeks is a reasonable time to deliver the baby. Again, not evidence-based, but based on what is reasonable. Ductus venosus Doppler. Well, you don't use it for diagnosis. Frankly, if the ductus venosus is abnormal, it's very obvious because the baby will be this big, the umbilical will be abnormal, there'll be probably reduced amniotic fluid. So really the role of ductus venosus is in monitoring and delivery timing for early fetal growth restriction. And the Truffle study, the first Truffle study in early fetal growth restriction showed, this was a 3-armed randomized study. In those early growth-restricted babies that were randomized to computerized CTG alone, the survivors at 2 years had 85% normal or near normal neurodevelopmental outcome. In the late ductus changes group, that was 95%, and that was highly significant. So if we take survivors at 2 years, the outcome was significantly better for those that had late ductus changes, possibly because we waited a little bit longer and gained a bit of gestation. I don't know the answer to that. Just going back to SMFM, well, you'll note that SMFM takes a very purist view on this. Ductus venosus, don't do it. Middle cerebral artery, don't do it. Uterine artery, don't do it. We take a more pragmatic view and say, yes, of course. Ductus venosus is extremely important in early growth restriction. It's not just Truffle. Before us came Ahmet Bashat with large observational series and others, many others. showing ductus was strongly related to adverse outcome. So, of course, if you can do ductus combined with fetal heart rate monitoring, preferably computerized fetal heart rate monitoring, so that if either or are abnormal you deliver, then please do ductus venosus. So let's just take you through a case in the last couple of minutes of my talk. 38 years old, referred for screening, SGA anomaly scan, low-risk screening. She had ulcerative colitis and a previous myomectomy. Let me show you the measurements. Small baby, 275, 0.2nd centile at 21 weeks. Let's just see how the Dopplers go. Well, uterine was normal, but umbilical was not normal at that point. 24 weeks. Still a very small baby, as you'd expect. Raised umbilical PI. In fact, interestingly, it had gone from absent to raised, which can sometimes happen, particularly early gestations. The A wave was positive of the ductus. Let's move to 26 weeks. What do we see? The umbilical artery still raised, no redistribution, and the A wave positive. So we can wait. We have an abnormal umbilical artery, but it's not critically abnormal, and the baby is moving. 28 weeks, still a very small baby, as you'd expect, 0.5th centile. Raised umbilical artery, but cerebral Doppler showing a degree of redistribution. 30 weeks, the ductus venosus is beginning to look a bit abnormal there with a raised PI. And again, baby very small. And 31 plus 5, reversed end-diastolic flow, we decided to deliver the baby at that point, exactly in line with ISWOG guidance. You can see the ductus, A wave still positive, but the PIV is beginning to go up. So this is a classic situation, delivered the baby, 31 plus 5, steroids and magnesium sulfate. Baby was in good condition with normal cord gases, as you would predict, because ductus venosus was still positive, and the baby, apart from being anemic and jaundiced, did well. So I'm not going to go through this slide, I'm sure to your relief, but the ISWOG guidance from last year details very clearly what in our practice we would recommend in terms of Doppler and CTG management of small babies, depending on what gestational age they are. So the Dopplers you do and how you interpret them depends on the gestational age. So there's no one Doppler for all gestational ages. I'll just leave you with this thought that we have many tools. This is a question of intelligent use of all those tools, bringing them together in algorithms that lead to best management. It's not about saying you can't do this, you can't do that, you can't do that. We have so many tools, we have a lot of information on them, and let's put this all together in an intelligent way. Thank you very much.
Thank you so much, Jerry and Christoph, for the nice presentations. The audience, feel free to stand and ask questions. We're going to start with the first question from the online audience for you, Jerry. Seems to be that delivery at 4.2 kilos to be a bit more intervention, or why not the cutoff 4.5 kilos? I hate cutoffs, I don't know if you like them.
Well, it depends also a little bit on the size of the mother, is it? If the mother has a weight below, height below 1.50 meters, do a cesarean section in all of them. Yeah. They say, usually, when she's 175, like in the Netherlands, yes, you can wait, if weight is 4.5 kilograms. So, in a way, we have to individualize a bit.
Absolutely agree.
Yes, actually, if there is no question, well, there are some, but let's move on with another question from the virtual audience. This one is for Professor Lies. How to explain low MCAPI at late pregnancy with normal fetal parameters in terms of movements, umbilical artery and uterine artery Doppler, normal CCTG, etc. What would you do?
Yeah, so the most likely thing, well, there are two possibilities if it's a very low CPR in a normally grown baby that's moving normally, biophysically normal, either just a false positive result, so I would repeat that measurement a few days later, possibly a week later, or the baby is actually showing very early signs of slowing down in growth. So in that case, almost invariably, you'd want to rescan at some point, whether that's 2 or 3 days afterwards to just check that, and perhaps 2 weeks later to look at the baby's growth.
I think we have a couple of questions from the audience, if you can stand. Sorry, can you have a mic?
Need a microphone?
I think it's fine now. No, it's not.
I'm sorry, we can't
sorry.
hear. Can you please?
Yeah, if you can move, if you can ask your question, and I'm sorry if you can move for the other mic, thank you.
Yeah, thanks. A question for Christoph. And the case you showed us, I mean, we come across, of course, the raised PI and umbilical artery Doppler, and we monitor and then gradually becomes absent and diastolic flow. But the case you showed us, I mean, I could see that the Liquor appears normal. So how much should we be reassured by normal Liquor Doppler that it's increased resistance in the umbilical artery and then gradually becomes absent and diastolic flow, so long, of course, the other parameters are good. So the normal like or normal movements, baby is growing between one scan and the next. So, I mean, I think this is reassuring, particularly early in the pregnancy, but should we be more worried about the raised PI and the umbilical artery more and delivered earlier, even in spite of other parameters?
Yeah, okay, so I think your question is directed towards the whole question of biophysical profiles, so movements and amniotic fluid. I think I would regard amniotic fluid as important collateral information, but not crucial information for decision making. So a small baby may still have normal amniotic fluid, but quite significantly abnormal Dopplers. And I'd still base my management on the Dopplers, the CTG, and the size of the baby. And of course, small babies do have a slightly higher risk of congenital defects, so it's not unknown that you might have a baby with a tracheoesophageal fistula or something that is very small, but normal amniotic fluid. So I think this is where it's important the UK practice and US practice is different, because biophysical, if you score a Doppler or CTG the same as you score amniotic fluid, it's going to be quite difficult to make the case for a baby that needs delivery. Whereas if you say growth and Dopplers are the most important thing, and movements are important, but they're collateral information, amniotic fluid is collateral information.
Okay.
In a longitudinal study, observational study on early growth restriction, we found already reduced amniotic fluid 5-6 weeks before delivery.
Yeah, I mean, this makes it easier. When the Liquor is reduced, then this makes it easier. It's the dilemma is when the Liquor is normal. That's just how reassuring this should be.
Yeah. So for the early onset, So for the early onset FGR, when would be the trigger to start or to offer the steroids? Would you wait for the abnormal ductus, or would you act on the reversed end-diastolic flow in the umbilical artery? And after how long, if you manage to push the lady for example, 10 days, would you offer a second dose of steroids, or you would not offer a second dose of steroids? Thanks.
So you asked about reversed umbilical and diastolic flow, and would you offer a second?
Yeah, so if you manage with the close monitoring, sometimes we can see that they can stay for more 10 days afterward, and then you decided to deliver. Will you offer a second dose of steroids, a second course of steroids? Thank you so much.
Okay, so if there's reverse end-diastolic flow at 30 to 32 weeks, we'd be suggesting delivery, and certainly at any point after that. Steroids, we showed in Truffle 1 that actually steroids do not have a clinically significant effect on Doppler parameters. They do have a slight they have a statistically significant effect on STV, but only a tiny effect on STV. So we regard the effect of steroids on Dopplers as negligible. I don't normally take that in our practice. We don't take that as important, and I would always give steroids as planned. anyway, so 12 hours apart if you've got reverse end-diastolic flow, because you'll be planning delivery relatively soon. There is a whole discussion about steroids and early growth restriction, isn't there, that we might come on to a little bit later about whether they actually are of benefit.
If you look at some recent data, I think it was early this year, corticosteroids given before 34 weeks of gestation help improve outcome. Given after 34 weeks in gestation, they increase problems in later age on development, neurological development. So, and that holds for steroids given in all kind of indication. We have no scientific proof that steroids do help at all in case of fetal growth restriction, because they were excluded from all the randomized controlled trials. And that's a study, I think, that we still have to do.
Yes.
Before I'll go for you, Jerry, I have a question for you from the online audience. I think it's Professor Enrico Ferrazzi. How do you counsel about third and fourth degree perineal laceration?
I don't. Well, and it helps that if you look at the Cochrane data, that there were more third to fourth degree laceration in case of induction of labor than in waiting. But I can imagine that if weight is more than 4.5 kilograms, that nowadays you might have to counsel.
Thanks. Yes, it has definitely to be considered a major adverse outcome of labor, so yeah, of course it has to be. Okay, next question, please.
Okay. My question is for large babies, as this is all I do in my practice, type 1 and 2 diabetes, and very often in the third trimester, early in third trimester, you already see macrosomia, sometimes polyhydramnios, and I'm very jealous of Chris giving a lecture about do Dopplers, deliver this, and that, and for large babies, we don't have like clear cutoffs when you should increase monitoring. How do you monitor if umbilical artery Dopplers really don't have any value for well-grown babies? CPR has no value. We don't have any other methods, I think, from fetal monitoring. So I guess my question is, when you do increase monitoring for macrosomic babies, what kind of monitoring, how often, and how do you decide in the very 37 to 39 weeks, what's going to tell you when to deliver that baby? Because those fetal stress tests are not reassuring.
Thank you very much. A very important question, and I can't give you an answer. We don't know. Do Dopplers help in big babies? They have normal Dopplers in the umbilical artery, etc. Maybe a redistribution of flow, but that never has been demonstrated, so please study that. Should you make fetal heart rate recording at 37, 38 weeks in case of a large baby? If it's moving a lot? No. There's only one thing that I think is important. Look at the glucose values in the booklet that she brings. Okay, here and there you have a glucose value above 12 millimole per liter. Was the baby moving at that time? And some will say, yes, it was moving. Others say, I don't know. And then I would say, next time, please look at it. And some will say, very strange you asked that question, doctor. When I have a high glucose value, my baby stops moving. Those are the ones at risk, and there is a logic behind it. So routine screening, unfortunately, we've never shown that anything is really significant. Very good question. Thank you very much. Thank you.
Look, we are extremely sorry, but unfortunately, we are completely run out of time. Otherwise, we cannot do the transition of the sessions. I'm extremely sorry. We have a line of people to ask questions and a large number from the audience as well that I won't be able to respond. I'm sure that Jerry and Christoph, you'll be more than happy to have a coffee with you and to answer your questions. This is certainly a very popular topic. I think that we still have a lot of controversy, but we really appreciate your thoughts.
We can have breakfast all together now.
You can have breakfast.
But it was too early for breakfast.
Yes. Thank you so much.
Thank you.